In this lecture, we will discuss the EKG features of biventricular hypertrophy. Biventricular hypertrophy occurs when the right and left ventricles are simultaneously hypertrophied. Unfortunately, the EKG has a rather low sensitivity for detecting biventricular hypertrophy, which should make sense. There are strong opposite directed electrical forces from each ventricle that tend to cancel each other out. And as you can imagine, the EKG will actually appear normal in some cases due to this partial cancellation of the hypertrophied ventricular forces. Okay, so if you look here, we have our forces. Here's our right ventricle. Okay, here's our right ventricle, and this is our left ventricle. Okay, and notice that our right ventricular forces are heading rightward and anterior, and then we have our leftward forces, okay, heading both posteriorly and leftward. Okay, and we have both of these ventricles that will thicken and get enlarged. That's what we mean by biventricular hypertrophy. Okay, and we're saying that the EKG has a low sensitivity because if these are spreading in the opposite direction, okay, so we have forces going this way and going the other way, you can see that those will cancel each other out, and sometimes we can see a normal EKG. Now, despite the low sensitivity of the EKG, there are some features that may provide us some clues, okay, and let's take a look at them. So first off, the EKG must suggest left ventricular hypertrophy, okay, and if we see that, we should suspect concomitant right ventricular hypertrophy if we see the following: right axis deviation, which is greater than positive 110 degrees, okay, which never occurs in leftward or left ventricular hypertrophy. We should also see deep S waves greater than 6 millimeters in lead V5 or V6, large RS complexes in multiple leads, and P pulmonale, which is a sign of right atrial enlargement. We won't go through all the criteria for left ventricular hypertrophy. Okay, you can refer back to our other lecture if you need that, but let's go through the criteria we have listed here. So again, the EKG criteria needs this left ventricular hypertrophy criteria met, okay? And then we're pretty much adding everything else on. So first we have this right axis deviation. So remember, normal axis is between negative 30 and positive 105 or positive 10 degrees, somewhere in that region, okay? And now we're saying that if we have the criteria for left ventricular hypertrophy met, okay, something that can point us to the right ventricle also being hypertrophied is the shift in our QRS axis heading this way, okay, and rightward in that region. Okay. The other thing is seeing in V5 or V6, the left lateral precordial leads, deep S waves. Okay. So if you imagine this was V5 or V6, and this is our R wave, this is our S wave, we want to see these deep S waves that are greater than 6 millimeters or 6 small boxes in depth. In multiple leads, we want to see these RS complexes, okay? RS complexes, here's an R wave, and this is an S wave. We call that an RS complex, okay? We want to see P pulmonale, okay? And that's where we see an increase in the P wave amplitude in leads 2 and V1, so this is called P pulmonale. This is a sign of right atrial enlargement, okay? Pulmonale, because this is often due to lung issues. Now notice here in lead 2, we want to see an increase in the P wave amplitude that reaches at least 2.5 millimeters or 2.5 small boxes, as we do here. And then in lead V1, if we have a biphasic P wave, we're looking at that initial portion of the P wave, okay, not the terminal portion that represents left atrial depolarization. And in this case, it should be at least 1.5 millimeters in amplitude, okay. So hopefully those all make sense. Now there is one interesting pattern that I want you to at least hear about. It's known as the cat's watchtail phenomenon. This pattern occurs when there are tall biphasic QRS complexes in the mid-precordial leads. Okay, so from leads V2 up until V5 we can see that. And this pattern has been reported to be associated with biventricular hypertrophy secondary to large ventricular septal defects or patent ductus arteriosus with pulmonary hypertension, which in this case you may hear and refer to as Eisenmenger syndrome, okay? So this last thing I wanted to mention here is this cat's watchtail pattern or phenomenon where we see tall biphasic QRS complexes in V2 through V5, okay? So if we erase this, what we're saying is imagine these are leads V2 through V5, okay? And we notice that we have tall biphasic QRS complexes, biphasic, right? Both, we have pretty much an R and S complexes as we mentioned earlier, all right, that are biphasic, equal in amplitude and in depth and as well as height. And notice that these are things that we'll see in V2 through V5, all right? And often you'll see this in children with large ventricular septal defects, okay, and maybe associated with that Eisenmenger syndrome that we discussed earlier. All right, let's briefly review what we discussed before we end. So remember, biventricular hypertrophy just means the right and left ventricle are both hypertrophied. Remember, the EKG has a low sensitivity for detecting it, and sometimes you can have a normal EKG because of that cancellation of the electrical forces. Now, what you want to see is first meet the left ventricular hypertrophy criteria, okay? And if you've met that and you see right axis deviation that's beyond 110 degrees, then consider biventricular hypertrophy, okay? If in V5 or V6 you see these deep S waves, okay, that are greater than 6 millimeters, also consider it. And in multiple leads, if you see large RS complexes, okay, where we saw here's an R and here's an S, an RS complex, that may also suggest it. We also said P pulmonale, which is a sign of right atrial enlargement, okay? If we have our right ventricle working harder, and if it gets stiffened, it may push blood and make the right atrium also enlarge, okay? In that case, what we would see is this P pulmonale in lead 2 or V1, okay? In lead 2, we would see at least 2.5 millimeters in our P wave amplitude, and then in V1, at least 1.5 millimeters in the height of that P wave, the initial portion of the biphasic P wave. And then lastly, we mentioned this Katz Watchstill phenomenon, often seen in children with large ventricular septal defects, where we see tall biphasic QRS complexes in those mid-precordial leads from V2 all the way up until V5. You can see them. Well, that's the end of this lecture. We discussed the EKG features of biventricular hypertrophy. I hope you learned something.